Hi, everybody. My name is Adam Pick, and I'd like to welcome you to the webinar titled The 3 Questions to Ask Before Mitral Valve Surgery. If I have yet to meet you, I'm the patient who started HeartValveSurgery.com all the way back in 2006, nearly 18 years ago. The mission of our website is simple. We want to educate and empower patients just like you. And this webinar, which has had over 650 patient registrations from people in countries all over the world, was designed to support that mission. Now, throughout the webinar, you're going to be in what's known as listen-only mode, but I encourage you to submit your questions in the control panel on your screen. And as we look at the agenda, it'll become clear why that's so helpful. We're going to introduce our featured speaker. We're going to start the discussion with a really great patient case study to set context to the meaning of mitral valve surgery. We're going to get into the 3 questions. Then we're going to have our own Q&A section. And lastly, I'm going to ask you to complete a very quick 5-question survey that's going to come onto your screen. Now, when it comes to the featured speaker of today, I am humbled that he is taking time away from his very busy practice in Cleveland, Ohio. And who is he? Well, Dr. Marc Gillinov is the chairman of cardiac surgery at Cleveland Clinic in Cleveland, Ohio. His practice or his specialties are mitral valve, aortic valve, tricuspid valve, aortic aneurysm, and atrial fibrillation. And I'd submit to you, he's not just a specialist when it comes to valves. He is a super specialist, having performed not 1,000, not 2,000, but 5,000 heart valve repair and heart valve replacement procedures. How does he do it? Well, Dr. Gillinov is a specialist when it comes to minimally invasive techniques we're going to talk about today, including robotics. He's an inventor. He's an innovator. He's a researcher. His name is on over 400 scientific journal/papers, and he's the co-author of Heart 411. Now, personal story about Dr. Gillinov. When I started this website, I got to tell you, I didn't know what I was doing. And it was right about the time that I got to meet Dr. Gillinov in about 2009. And he said to me, "Hey, Adam, you are onto something very powerful and positive for patients, and I encourage you to keep it up." So he's not old enough to be a grandpa of HeartValveSurgery.com, but Dr. Gillinov, you're definitely an uncle. And you have supported us through educational materials, your time. You've helped so many people, and you've provided extraordinary care. How much care? Well, what you see in front of you, I went back and I looked at our database of patients, and I did a search for Dr. Gillinov success stories. And here you can see whether it's Dan Spots, Kathy Gazin, Alan G. and Greco. These are all patients from where? The HeartValveSurgery.com community who have gone to Dr. Gillinov and had successful mitral valve surgery. And if the names aren't enough, how about some pictures? There's Anita Devine from New York. There's Jeff Porofsky from Arkansas. This is great. Here's a patient reunion of Dr. Gillinov's patients in Austin, Texas. There's Jenny, Randy, and Lisa. And here is the mother-son story of Kathy and Carter Chelton. Yes, mother and son who both needed what? Mitral valve surgery by who? Dr. Gillinov. Here's more pictures. This is Dr. Gillinov in the operating room. This is him at the Robotic Council. This is Dr. Gillinov and I in Abu Dhabi celebrating National Heart Valve Day a few years ago. And with that introduction, I just can say one thing. Hey, Dr. Gillinov, thank you so much for everything you've done to support our community over the years. And I'm thrilled to have you here with us today. So I'm going to pass it over to you for the presentation.
Great. And thank you, Adam. You had a vision and you reduced it to reality. You made it happen, which is pretty amazing because there is no one like you and there's no one who does what you and your team do. And I know that you make people feel better. You make them feel less anxious. You share stories. And really, that is super important because, like I said, all I do is operate and talk. And I think you speak better than I do. But I'll get right to it anyway. Mitral valve surgery is, in general, not the most complicated heart surgery in the world. But just like anything else that you do, whether it's you're looking for a new computer or something more important like your heart, you need to do a little bit of research and ask some questions. So I'm going to outline this talk with the 3 questions I would ask if I found out I need mitral valve surgery and I was going to a surgeon or a cardiologist, but likely this is what you should ask your surgeon. What do you need to know? Next slide, please. And these are some companies that I've had the pleasure of working with. They're all very innovative. Next slide. So who gets mitral valve surgery? And for the most part, I'm going to talk about degenerative mitral valve disease, which is also called mitral valve prolapse, which is also called myxomatous disease. So degenerative equals prolapse equals myxomatous. But who are these people? Next. They're people like this. Someone who is young and healthy. A 52-year-old triathlete came to me asymptomatic. This guy feels great. He's completing Ironman length triathlons, which means that's a full marathon in there. But he was found to have a heart murmur at his annual physical. Annual physical is a good thing to do still. And he underwent an echocardiogram, which showed that even though he felt great, his mitral valve was leaking. Next, please. So what does that mean? It means heart surgery. And of course, that is an unexpected turn of events for a 52-year-old triathlete who feels perfectly fine. Next, please. And of course, here's the reaction. How could this be? How could I be having heart surgery? I have no chest pain, no shortness of breath, no swelling in my ankles. Why do I need surgery? Next. And the answer comes in this echocardiogram, which we'll show you on the next slide. And this is a transesophageal echo, meaning that the person has been sedated and the echo probe has been placed in the mouth and down the esophagus. And the reason that works is that the heart sits right in front of the esophagus. So this is an ultrasound of the heart. And what you see to the right is something kind of flapping up there. And if we go to the next slide, what you're going to see is the leak. This mosaic of color represents mitral regurgitation or the leak of the mitral valve. That's blood going backward from the left ventricle that's squeezing at the bottom of the screen up through the mitral valve, which in normal circumstances is supposed to seal nearly completely. So this is what we call severe mitral regurgitation, and this needs to be fixed. Next, please. He had 3 questions. Once he got over the concept that I'm a 52-year-old triathlete, I can run laps around my surgeon and I'm going to have surgery. His 3 questions were the timing. Do I really need this now? The operation itself. What are you going to do to my valve? Are you going to repair it or replace it? And then can you get there through a robotic or less invasive approach? These were the big 3 questions he had written down on his iPhone when he pulled me up. So let's go first to the next slide, the timing of surgery. Should he have it now when he feels fine, he's young and healthy, or should he just wait? So next, please. The answer is have it now. And the timing question used to be fairly controversial, but not so much anymore. The valve is broken. It's not going to fix itself, and it's going to cause problems if left alone. Next, please. So this is what we said. Your valve is broken. You feel fine, but it's broken, and severe mitral regurgitation on a scale from 0 to 4. If you've got a 4, that is inevitably going to cause heart damage. You may feel well today, but that's not going to last. And there is no advantage at all to watchful waiting. The debate used to be, you feel fine, okay, let's get an echo every 6 months. And with this watchful waiting strategy, which is a bad strategy, the idea was we will do your heart surgery and fix your valve as soon as you start to have heart damage. Who wants to have heart damage? Don't wait for heart damage. Fix it when you recognize it's broken. Next, please. But again, he said, can't I wait? I feel fine. And the short answer is, it's not an emergency. Yeah, you can wait a few weeks, 2-3 months, but not 6 months, not a year, not 6 years. Next, please. Because waiting can be dangerous. And let me show you what happened to someone who decided to wait. Next up, please. So this is a different patient, 79-year-old retired insurance executive, really good health coverage through his company, also no symptoms. He had had a heart murmur heard at his annual physical 2 or 3 years in a row. He got an echo, which showed the same thing, prolapse, P2, P means posterior, 2 means the second part of the posterior leaflet. So this is the middle of the posterior leaflet. It's the most common cause of a leak. And he had severe mitral regurgitation. And after a couple of years of watching this, his cardiologist referred him for what he thought was early surgery, because he said this is early in that this patient has no symptoms. Well, he didn't have symptoms, but if you look at the next slide, you'll see this is his heart. This is, next slide, a very enlarged heart. Your heart is not supposed to be this big. If your heart is this big as his was, this means his leaky mitral valve, even though he feels fine, his leaky mitral valve has already caused heart damage. Because on the next slide, you'll see what your heart's supposed to look like. This is a normal size heart. His was 1.5 to 2 times as big. So next slide. He had surgery and he did well, but no doctor can reverse heart damage that's already occurred. So don't wait. Don't be like that patient who, in fairness, was not advised to have early surgery. But if the valve is broken, get it fixed. And the second question is, what do I mean by getting it fixed? Does that mean repair the valve or replacing the valve? Next, please.
Dr. Gillinov, before we go on to the second question, I'm sure there's some patients on the line who are newly diagnosed. Maybe they have been in watchful waiting. And what I noticed in your prior slides was the use of the word severe for describing mitral regurgitation. We know this is a progressive disease. So what should patients be thinking if they've been told they have maybe just moderate regurgitation, moderate to severe? What would you recommend for them as they're thinking about timing surgery?
That's a really good question. If the regurgitation is graded as moderate or 2 out of 4, no surgery at this time, because you can live to be 100 years old with moderate regurgitation if it stays that way. If it's moderately severe, let's call that 3 out of 4. And we often call it 3 plus, but it's not 3 plus means more than 3. We just call it 3 plus. So if you've got moderately severe or a 3 out of 4, if you have symptoms or if you have any change in your left ventricle, meaning it got bigger or its function is down, you should have surgery. And if you have 4 or severe regurgitation, that's easy, have surgery. So if you've got 2, waiting is 100% the right thing to do. Get an echo every year. If you've got 3, think about how you feel and ask the question, how is my heart? Has my heart enlarged? Do I have any sign on your echo, any sign that my heart's paying a price for this? Because if your heart is paying a price, meaning it's getting damaged, or you're paying a price for 3+ or moderately severe regurgitation. You're paying a price, meaning you don't feel as good, or you've slowed down. You used to run 3 miles. Now you can't walk 3 miles. If there's a price being paid, you should get the valve fixed.
Great. Thanks so much.
Oh, you're welcome. So second question is, what does fixed mean? So we'll go to the next slide. For prolapse, and this is not talking about people who have rheumatic heart disease and other conditions. For mitral valve prolapse, which means the valve is kind of floppy, mitral valve repair is the gold standard. That's what you want for your valve. Next slide. And the data goes way back, more than 40 years. Carpentier, a French surgeon, described mitral valve repair, and he called it the French correction. And then his long-term results over 20 years showed that, hey, these repairs last a long time, which was not known at that point. Then other surgeons found, hey, we can repair almost all of these degenerative valves. And it turns out that, as Carpentier, the father of mitral valve repair, said, they last a long time. And more recently, we found we can do most of these operations through little incisions with robotic assistance. But regardless of approach, mitral valve repair for prolapse is the gold standard. That's what you want from your surgeon and your surgical experience. Next up. Why do you want repair? What is the advantage? Well, it's pretty simple. Mitral valve repair, next slide, is somewhat magical. And I'll show you why in the next slide. If you get a valve repair for degenerative disease or prolapse, you have the following benefit on the next slide, which is quite simply, you live longer. This is a graph showing how long people live if they got a repair on the blue line versus replacement on the red line, and you see the separation. People who get a mitral valve repair, in general, live longer than people who get a mitral valve replacement. So this is the single reason that you should ask your surgeon, what is the likelihood that you and your team can repair my valve? Next slide.
Dr. Gillinov, I got to ask, if you are a patient and you have mitral regurgitation, you see a physician, you've been told you need a fix, and you're told that they're going to do a replacement for you, what is your advice to patients? Because I've had that exact situation with patients where they've been told, hey, I have mitral regurgitation, but my surgeon's telling me to get a replacement. What's your recommendation for them?
Get a second opinion. I think you should always get a second opinion for something as important as your heart, and it's worth your while to do so. Sometimes this can even be just a video conference. There are a few kinds of mitral regurgitation where replacement might be a better option, but there are a select few. And if your diagnosis is mitral valve prolapse, then you should be talking about repair, and your surgeon should be discussing repair, because that's what's going to make you have a normal life expectancy. Replacement sometimes is inevitable, but repair is better. And we want the best. You want the best. And for this patient, you can go to the next slide. That was perfect. This patient we presented, back to the 52-year-old triathlete who feels great, he's got what's called posterior leaflet prolapse. The mitral valve has 2 leaflets or flaps. One is termed the anterior leaflet, the other the posterior leaflet, and they meet in the middle, sort of like the doors at the airport. As you walk up, they slide apart, and then they rejoin each other. Posterior leaflet prolapse affecting the posterior part or back of the valve, is our sweet spot. It is the easiest to repair. It has outstanding durability, and the operation is incredibly low risk. It's almost like getting your appendix or your gallbladder out. Next slide. So one of my friends and colleagues, Doug Johnston, when he was at Cleveland Clinic, looked at repair of posterior leaflet prolapse. This is what 70% of people who have prolapse have, this posterior leaflet effect And if we look at the repairs on the next slide, what we find is a few things. First of all, the operative risk, the risk of not getting through surgery, is under 1 in 1,000. Or to flip that around, if you come into the hospital with posterior leaflet prolapse and you're going to get a mitral valve operation, ideally repair, the risk of you dying is under 1 in 1,000. So this is an incredibly low risk operation. Yes, it's heart surgery. It's a big deal, but it's very low risk heart surgery. Next, please. And the reason we want to repair again, and I want to emphasize this, that's why we've got a similar curve up twice, is these are two survival plots, meaning how many people were alive after surgery at 4, 8, 12, and 16 years. And after a mitral valve repair on the blue line, you're pretty much the same as people we matched from US Census Bureau data. And what this means is if you had a mitral valve repair for prolapse, it's as if you never had heart disease. You are back to a clean slate. You're normal. You had something wrong with your valve. It got fixed. It's like a car that was in a fender bender. It's not the whole valve, just a part of it. And look what happened. You were restored to a normal life. And this is why repair is so important to me and should be to you. Next, please. Now, not all repairs last forever, and I just want to make that point. If you've had a repair, usually it will last forever. At 14 years, 95% of people have not required a reoperation, but if you did get a repair, you should get an echo once a year. And on the next slide, what we'll see is there is some return at 10 years. About 10% of people might need a reoperation, meaning they're on that bottom curve, meaning their return of mitral regurgitation is at a level of 3 or 4. However, the other 90% are at 0 regurgitation or close to 0, I should say, because no one's really 0, but close to 0, 1 or 2, and those are A-OK. You can live with that. Ideally, you're 1 or less, which is the majority of people. But the point here is you will likely have a normal life expectancy, but 364 days a year, forget about your valve. 1 day a year, get an echo to check on it. Next slide, please.
Dr. Gillinov, I've got to ask you, you've
Sure.
highlighted all the advantages here of the return to a normal life expectancy, being normal just even with this disease, the lack of mortality. But I'm sure patients might be wondering, does this apply to all cardiac centers? Where is this data coming from? Are you collecting it from across a massive database, or is this specific to the Cleveland Clinic?
These are the Cleveland Clinic data. However, across the country, across the entire US, in general, the risk of having a mitral valve repair is about 1% or a little bit less, which means 99% success in terms of surviving surgery. And that's really good. I'd say 1 in 100 people in the US won't make it through mitral valve surgery, but at Cleveland Clinic, it's actually more like 1 in 1,000. And I think that relates to just the team that we have. And I'm sure that there are some other medical centers that also have, just tremendous resources and teams. But virtually everyone who goes in for a mitral valve repair should be thinking about, I want an experienced surgeon, and not just a surgeon, a center that does this every day, day in and day out. Because to your point, these are our Cleveland Clinic data with super low mortality. And again, it's not exclusive to us, but we are fortunate in that we do more mitral valve surgery than any place in North America. And I think, I don't play golf, but people who do tell me if you do it every day, you get better at it. So I would hope the same has been true with surgery over the last 40 years at Cleveland Clinic.
Great. Thanks so much.
Oh, you're welcome. So answer number 2, number 1 was timing, get it done now or soon. Number 2 was, what are you going to get done? A repair. So now we'll move on, next slide, to question number 3. You want to know, can you kind of sneak in there with the robot and get my valve fixed? Because I don't want to look like I had heart surgery and I want a quicker recovery. And the answer requires a lot of discussion. In his case, the answer was yes. The next slide, please. There are many ways to get to the mitral valve. And they're seen here, starting at the top left, a complete sternotomy, which works great. Bill Clinton, David Letterman, Arnold Schwarzenegger, many people, millions of people have had a sternotomy, and this heals very well. To the right of that, going clockwise, would be a partial sternotomy. That's another way to get to the valve. You still cut some of the bone. Then in the bottom left, many people, surgeons, will do an anterolateral thoracotomy, which is less invasive, or the least invasive, bottom right, is a robotic approach, which you see those three circles. Those are little ports that we make, which are about 1 centimeter long, and we put instruments through that are a little bit thicker than a big pen. And then there is an incision, which is marked by this red line on the right side of the chest, or to your left, right there. And that incision usually is quite small, maybe 1 inch or 2 inches. And this is our least invasive approach to the valve. Next slide. Why did he want robotic surgery? Faster recovery, smaller incision, and this just general statement we hear a lot, I don't want my chest cracked. So on the next slide, what he's talking about is a sternotomy incision, which is the most commonly used incision for heart surgery. Again, it heals well, but next, his gut instinct was, I don't want that. Unless you have to do that to save my life, I'd like something on the right side with the robot. Next slide. So here is a schematic illustration of what robotic surgery looks like. And it's actually, ironically, a collection of incisions, but each one is small and heals quickly. So that's robotic surgery. And while people recognize your heart is more on the left side of the chest than on the right, the approach to the mitral valve with the robot is from the right side, because that enables us to look at the left atrium, which is where the mitral valve lives. Next slide, please. The question for robotic surgery isn't can a surgeon do it, it's when should the surgeon do it. Next slide. This is a slide that really states our guiding principles for robotic surgery. First of all, as I said, all patients can have it, though not all should have it. In order to do robotic surgery well, we've got to be able to look at the patient and look in the mirror and say, we're doing the same operation with the same safety, and we're going to have a successful repair. And that means we've got to choose the patients wisely and well. And as we've become more experienced at the Cleveland Clinic, we've done more than 2,400 cases. We've extended our criteria because we can do it relatively quickly now. But the robot is just a surgical tool. It's a super advanced, amazing tool. But like any tool, you've got a tool chest. You open it up, you've got to decide which tool is the best for the project at hand. In this case, the project being fix your mitral valve. Next slide. So I'm going to show this in bigger print, so don't strain your eyes. But after our first 1,000 robotic cases, which was about 7, 8, 9 years ago, we determined how we judge or screen who is the best candidate for robotic surgery versus non-robotic surgery. Next slide, please. And these are our data most currently. Actually, as of today, we're at 2,418 robotic cases because we did 2 Monday, 2 Tuesday, 1 Wednesday, 1 Thursday, and a couple last week. But these are what we have been able to achieve by careful selection and application and expertise. We always do this as a team. Right now, my partner, Dr. Tarek Mellis, and I do the robotic cases together. Next slide. First of all, what's the risk? Under 1 in 2,000. So the chance of getting through surgery is greater than 1,999 out of 2,000. Next slide, please. And our repair rate with the robot is 99.8%, meaning that we know how to repair the valve with the robot, and we know which maneuvers are suitable for the robot. Next slide, please. A lot of this depends on the preoperative studies. Today, I was reviewing a chart where the patient had had an echo to look at the valves, a cardiac cath to make sure that there are no blockages in the arteries, but this patient had not yet had a CT scan, a CAT scan of the chest, abdomen, and pelvis, which we need as a roadmap to tell us if robotic surgery is safe. But this patient had had an echo and a cath and had been told, you're good for robotic surgery, that's what we're going to do. And she sent me her records, and we got back to her right away and said, please send the CT scan. And she said, well, I don't have one of those. And I said, well, don't have any semblance of robotic surgery until you have a CT scan, because that's how we determine how to get where we're going. That is our roadmap. Next slide, please. So here's how our preoperative testing boils down. Before surgery, we need an echo and a CT scan in addition to the cardiac catheterization. Next slide, please. And if certain criteria are met, we get through this algorithm, we are able to do it robotically. If there is a leak to the aortic valve, which may need treatment or will complicate surgery, you don't want robotic surgery. If there's a lot of calcium in your valve, an open approach is probably best. And certain heart conditions are best treated with an open approach. Those are determined by echo. The CT scan is equally important. When we do robotic surgery, we generally hook up the heart-lung machine by putting a tube in the artery and vein to your leg. And we send the blood from the heart-lung machine into the artery in your leg, which means we're sending the blood backward. As we're all sitting here now, our hearts are pumping and sending blood from our chest toward our toes. With robotic surgery, we reverse the flow of blood. And what that means is if there is some plaque or blockage in the arteries to your leg or in the arteries in the abdomen, a piece of that could get broken loose by the reverse flow of blood, and that would potentially cause a stroke. So that's the main reason to get a CT scan, to get a CAT scan, to avoid strokes, because stroke is amongst the most devastating complications. And I'm pleased to say in our experience, it's very rare, but I think that's because we plan ahead. Next slide, please.
Dr. Gillinov, I've got to ask you, I've heard you lecture and talk about safety, robotics, mitral valve surgery. And it's fascinating to see this algorithm that your team has put together and the constraints around doing robotic mitral valve surgery. I'm curious to know, you talked about stroke and risk. How does atrial fibrillation play into a situation for a patient with mitral valve disease? Because I think the data is about 35% of patients with mitral valve disease may have some form of AFib, and I know you want to prevent strokes. Can you manage both robotically?
Yes, you can. Yesterday in the morning, I did a robotic procedure on a patient with a history of atrial fibrillation, and we did a maze procedure with the robot. The thing is, though, in my opinion, we don't do quite as complete an ablation of AFib or a maze procedure with the robot as we do through a sternotomy. And the reason for that is that the tools we use to do the AFib procedure, the maze procedure, are designed to be used primarily through a sternotomy. That said, I feel like we can do a pretty good job with the robot to treat both the AFib and the mitral valve. The other factor that goes into that is robotic surgery, if it's early in the surgeon's experience, definitely takes longer. And you don't want to have someone on the heart-lung machine for an excessive period of time. So in our first 1,000 cases, we did not treat AFib with the robot very often because we said, look, just dealing with the mitral valve with the robot's going to take a while. At this point, the times are equal to an open procedure. And what does that mean? It means that, short answer to your question is yes, we could do a good job with AFib with the robot now, but that's after a lot of experience.
Great, thank you.
Oh, you're welcome. And again, the main point here was going to be get that CT. If your surgeon says we can do it through the right chest or do it robotically, that's wonderful, but make sure you've had a CT scan. And I'll show you why. Next slide. This is the kind of CT scan we're looking at and we're looking for. To your left is a three-dimensional reconstruction. You can see the ribs are sort of cut away, and you're looking at an actual person's heart, which is just amazing. To your right is a slice of that scan. This would be if a patient's laying on his or her back, and the top is the front of the patient, the bottom is the back. Outlined in white are bones. So that rectangle at the top that's outlined in white, that's the sternum. And then at the very back is the spine. And in the middle is the heart, and the circle at the top is the aorta. And you want to see that's very clean. There's no plaque in there. Next slide, please. In contrast, some people will have atherosclerosis or plaque or blockages. Next slide. And this was a paper that got a lot of publicity and a lot of quotations in cardiac surgery. And it suggested that if you have an operation where the heart-lung machine is attached to the leg, you were more likely to get a stroke. But this was without scanning people. And scanning people is key. Next slide. And I'll show you why scanning is key. So here's another case, 57-year-old man, has severe mitral regurgitation. Primary mitral regurgitation means that it's caused by prolapse. If you look at the bottom two echoes, this is a transesophageal echo. To the left, you see toward the left part of the screen, that thing flapping in the breeze. That's the posterior leaflet, which isn't meeting its friend, the anterior leaflet. And to your right, again, you see this mosaic of color. That's the leak. So with this echo, he came and said, I want the robotic approach. I want you to hook up the heart-lung machine to my leg. And his cardiac catheterization, look at the arteries on his heart, suggested his arteries look pretty darn good. So maybe it's possible, but let's get a CT scan and see. So next slide, please. Here's his CT scan. And to the left, the white stuff you see that's in the artery, that's calcified plaque. And in the middle where there's blue and red, the red is the kidney on both of the portions in the middle figure. That white stuff where the arrow points, that is all plaque. So even though this person felt fine, he's got this white appearing calcified plaque, and to do robotic surgery on him without looking would be an absolute disaster. He would have a stroke almost for sure. So we fixed his valve with a traditional operation, and he did very well. Next slide, please. So what's good about the robot? Why do we do it? Next up. It's complicated. Yeah, it's not something that a surgeon can dally in. You've got to be with a team that does this every day. And here you see the surgical robot with these arms, which are encased in sterile plastic. And you see the people at the table side. There's a patient under all that looking at the screen where the robotic image is displayed. Next, please. What's really good about the robot is, next slide, the visualization. We have three-dimensional high-definition vision. I remember I was at a sports bar type place having a dinner with my wife, and we were watching on the television the Olympics about 3 weeks ago, and we were watching gymnastics, and she said, wow, that television has great resolution. We should get one of those. I said, its resolution is nowhere near what I see every day in the operating room with the robot. The resolution is absolutely spectacular, and we see in 3 dimensions, because if you look at that frame to the left, that's the camera, but there are 2 cameras on it. One for your left eye, one for your right eye, which means the surgeon has stereoscopic vision. Having 2 eyes is what gives us 3D depth perception. Next, please. Now, it's not just me, or here you see me standing there. I'm the guy, not so tall guy with the glasses. And to your right is Stephanie Mick, who is an outstanding robotic surgeon wearing all white in the in the operating room. We worked together for a long time, and she's now in New York City. But it takes this whole team of specialists to know how the robot works, how to do it, and to get you an excellent repair with extraordinary safety. Next slide, please. The operation itself is very, very cool. It's just amazing. We have visitors from across the country and around the world come to see robotic surgery, and I think it encourages them to get into the field. Next slide, please. The surgeon is in the room. So the black arrow points to a surgeon, and the patient would be over here just a few feet away. There have been a couple of transatlantic robotic operations where the surgeon is in New York and the patient is in Paris. I think I'd rather be a little bit closer to you if you're having heart surgery. So let's just do it all in one room. Next slide, please. And again, because the instruments are phenomenal and the camera's visualization is so perfect, we don't need to have our hands or our eyes in your chest. We can do it through these ports or small incisions. Next, please. And here's what it looks like in real life. So this is a patient. The head would be to your left, the feet to the right. And as I mentioned, you've got a collection of incisions, but a collection of small incisions, none of them through bones. And each one of these ports attaches to the robot and enables us to have perfect control from the console. Next, please. So what do we do for our 52-year-old triathlete? How did we get him back in the game? Next, please. We did what's called a triangular resection. Here you see a mitral valve, and the anterior leaflet is the bigger part at the top. The posterior leaflet is at the bottom. And you see the surgeon is holding up a bad piece of the valve, a piece where there was a ruptured cord. A ruptured cord would be sort of like someone's floating down on a parachute, and one of the struts to the parachute breaks. Same thing happens to the valve. The valve flails just like the parachute canopy would. So here what we did is very simple. We cut out a pie-shaped piece, triangular resection. Next slide, please. Then we sew that together. The valve tissue is kind of like skin. It's got sort of a flexibility to it, a bit elastic. So we can just close that little defect we created up. So normal valve to normal valve. Next slide. And then we put this ring around it, which we discussed a little bit earlier before the webinar started. This white ring with sutures in it, holding it in place, is called an annuloplasty. And you can think of it as being like a washer. It compresses the valve a little bit, brings it to normal shape and size. And this one is a U-shaped or C-shaped band. It could also be complete. Each of them works just fine. Next, please. And this is now the echo in the operating room, actually in the operating room after surgery. And what you see is the anterior leaflet of the mitral valve, which is the thing that's going down and up and down and up, is meeting the posterior leaflet, which is kind of like a doorstop. And we don't see anything flapping around, and we don't see any color, any leak going backward, meaning this valve now works, which is what happens when you do a posterior leaflet resection. Next slide, please. So in summary, when we're talking about the robotic approach, ask the surgeon, and the surgeon should ask himself or herself, in this case, in this person, does the robotic approach provide an equal repair rate? Meaning, I'm not giving up anything. I can do the same operation with the robot on your valve, and I can do it with equivalent safety, meaning we're not taking a chance. And these are the questions to ask. And if the answer is yes, next slide, then the yes goes with get it done robotically. So I think the robot is a phenomenal tool. We love it, but it's got to be used like any tool in your toolbox at the right time in the right place.
Well, Dr. Gillinov, thank you so much for the prepared remarks. I just learned a lot. I'm sure the folks on the webinar have learned just as much as me. So thank you for taking the time to put this together and sharing your insights about mitral valve surgery. We have gotten a total of about 59 questions submitted. So in addition to what you see on the webinar, my inbox is lighting up. So let's enter what we would call, Dr. Gillinov, a rapid fire session specific to Q&A. We only have so much time, so let's try and get as much in as we can. We've talked a lot about the robot, so maybe we can move past this, but real quick, people often ask, what about recovery? And this is coming from Christina. What should we expect in terms of recovery time, both in the hospital and at home? And are there any specific post-surgery complications we should be vigilant about?
Great question. Recovery with the robot is quicker than with a sternotomy, as you'd expect. Most people are in the hospital for about 4 days, and everyone says, I feel surprisingly good, but I am a little bit sore. It's like you have a pulled muscle, but you can drive when you get home after robotic surgery. And at about 2 to 3 weeks, let's say 3 weeks, people say, I'm feeling like 95% of myself. So a pretty quick recovery. The most common postoperative complication of any heart surgery is atrial fibrillation, an irregular heartbeat. And it happens in about 40 to 50% of people who have mitral valve surgery. But the key thing is it goes away, usually before people go home. But if you were home and you felt your heart going a little fast or skipped beats, not an emergency, not 911, but get an EKG.
Great. And let's continue with Christina's question. We answered a lot of what she asked here about the benefits in 1, but moving down to 3, how does the Cleveland Clinic monitor the success of a surgery? You've got patients coming to you from all over the country, all over the world. What type of metrics or observation do you use to say, hey, that was a successful patient?
Well, we're really, really dedicated and very compulsive about this. In the operating room, we do an echo at the end of the repair to make sure that we are happy with it. Then we do another echo before you go home, which is generally within the first week. Then we offer follow-up to the Cleveland Clinic, and if not with us, with your cardiologist at home, you should get an echo at 4 to 6 weeks, and then once a year. And please answer our surveys, because we try to collect all the follow-up we can, because that's what makes us better. I remember in the early 90s, we'd been employing a repair technique that looked great called chordal shortening, which we don't do anymore. And we don't do it anymore because we found over time, when we got enough follow-up, people filled out our surveys and sent us their echoes. It didn't last as long as other techniques. So we really, really, really want to monitor everyone with echoes. Whether you get it at our place or you live in Florida or California, please send us your echoes or echo reports.
Got it, Dr. Gillinov. I've got to ask you, we started this conversation with your success stories from HeartValveSurgery.com. We saw the pictures of the patients from New York, Arkansas, Texas. How many of your patients are from, I don't know that you have this data, are from Ohio? And how many folks are coming to visit you from or require some form of travel?
Oh, no, I have that data. Overall, at Cleveland Clinic, we do about 5,200, 5,300 open heart procedures a year. And overall, about half of the people come from outside of Ohio. For mitral valve surgery specifically, it's more like 75% come from outside of Ohio. So we've got everything very streamlined in terms of the travel. We have 3 hotels on campus. We send a car to get you at the airport, et cetera. Because having surgery, that is stressful enough. And then traveling for it could add another layer. And we want to make that as easy as possible for the more than 2,500 people who come each year.
Great. Let's kind of shift gears and let's talk about mitral stenosis. Got a great question from Seth, who asks, I have mitral stenosis and I'm in the waiting room. Is there any update on mechanical valves that do not require Coumadin or have lower levels of Coumadin required?
Also a great question. Short answer is no update. At this time, if you have a mechanical mitral valve, we still want you on Coumadin with an INR, which stands for International Normalized Ratio, INR, in the range of 3. There have been a couple of trials with specific types of valves trying to use a lower level of Coumadin, and they were not positive. So it's got to be Coumadin, and it's got to be at this level, INR around 3.
And if a patient is newly diagnosed, what can you share what Coumadin, the drug, does relative to the mechanical valve?
Sure. Coumadin is also called warfarin because we've got to have two names for everything in medicine to keep it interesting. And the issue with this mechanical valve, you see, the white part is the sewing ring. That's the part where we put stitches through your heart, then through that soft, fluffy ring. It's about the consistency of a shoelace. And the black part is the valve itself. And that black material is carbon. It lasts forever. It's super smooth, highly polished. But if you put this valve into your bloodstream, the blood's reaction to man-made materials is to clot. So if you put this in the bloodstream without anticoagulants, without thinning the blood, blood clots will form on the valve, which will either interfere with the valve function or go through the circulation and cause strokes. Therefore, if you get this kind of valve, it's called pyrolytic carbon, you get this kind of mechanical valve that lasts forever. The trade-off is you need to be on an anticoagulant, Coumadin specifically.
Got it. And let's move over to Bob's question. And we're talking about multiple valve operation. And Bob asks, my mitral valve is going to be repaired. My aortic valve will be replaced. Both valve problems have been described as severe. Is there any way this can be done through TMVR, transcatheter mitral valve repair, and TAVR, transcatheter aortic valve replacement? Or is open heart surgery the only option?
It can be done in many cases without surgery, but the question is that the best option for you? At the top, what you see is the mitral clip, which is something that is placed by a cardiologist through a stick in the femoral vein, meaning in the groin. And below that is a transcatheter aortic valve, which can be placed to replace your native aortic valve. One of the things we don't know is how long each one of these devices is going to work. Meaning, if you're 40 or 50 or probably even 60 years old, these are taking a chance. They may or may not last. However, if you're 85 years old and you're otherwise high risk for surgery, this may not be a bad idea to consider.
Great. Bob, I hope that helped you. Let's move over to Lynn's question, and I really appreciated this. It's about cardiac surgeon evaluation. And I remember as a patient, finding the right surgeon for me was not a simple process. And Lynn asks a question here. She said, I had a consult with a very experienced heart surgeon. He's 69 years old. How old is too old for a surgeon to perform open heart surgery on me? I'm 80 years old.
We just did a study of this in the Cleveland Clinic. We have surgeons who have ranged from 33 years old up to now 80 years old. And we found that thus far, surgeons continue to get better with age. Of course, there's a selection bias because some people who might have been 70 or 75 retired. But if you've got a 69-year-old surgeon and he or she looks lively and relatively youthful, then I think that is A-okay. I think surgeons are probably getting into their stride when they're in their 50s and 60s.
Right on. And so we have this fascinating question from Carol, who says, hey, I have a porcine mitral valve replacement that is failing. I'm 72. What are my reoperation treatment options?
The reoperation is extremely safe, and the idea is take the old valve out, put a new one in, and you would likely go for another porcine valve or a biological valve. In, again, selected instances, because this is new, we might be able to do a non-surgical valve-in-valve where we take a percutaneous aortic valve, meaning a TAVR valve, one designed to be placed through the vein or artery in your leg, and put it right in the middle of this valve when it's worn out. So it goes in the middle of this white circle. And it depends on the size of your valve and the veins in your leg and the anatomy. But if you've got a pretty good size, meaning a big valve in there, might be able to get this done without surgery.
Great. And so this is a question we talked and you showed earlier that the distinction of an enlarged heart for somebody who waits too long to have surgery. Here, Mayrab asks, what are the chances that the left ventricular ejection fraction will drop below normal after mitral valve surgery to the degree that the patient needs to be treated for heart failure? And the follow-up, Dr. Gillinov, is what are the chances that the ejection fraction can recover without or with medical treatment?
Also a good question, and getting to your point, Adam, of getting surgery early when you know the valve is broken. If somebody has waited until their heart has enlarged or their ejection fraction, EF or ejection fraction, has fallen, then we cannot predict if the heart will recover. Most people don't wind up needing to be treated for heart failure, but a normal ejection fraction in most people is 50 to 55. If your mitral valve is leaking, a normal ejection fraction with a leaking mitral valve is 65. So if somebody says you have a normal ejection fraction and severe mitral regurgitation, and then they say your number is 55, that's not normal. That means you've already got some heart damage. But in any case, probably about half of people recover with surgery and treatment. And having the heart being enlarged or the ejection fraction down a little bit isn't a reason to avoid surgery. It means you need it now to prevent further damage.
Got it. We also have a fascinating question from Dina, who asks, how often does a patient with severe mitral calcification have it continue to calcify after a successful mitral valve surgery? Are second surgeries common for patients with mitral valve calcification?
Short answer is almost never does the calcium come back to such an extent that the calcium it cause for reoperations. So it's uncommon. The arrow down there is pointing to calcium around a heart valve. And in cases like this, oftentimes you would have to replace the valve, and a safe replacement can be achieved, and the calcium does not come back and affect the replacement. And if you've repaired the valve, you usually remove the calcium. Same thing, does not come back.
Great. And then we talk often about bicuspid aortic valves and genetics. And Tim flips that script and he says, I see a lot of information about BAV being passed down genetically. What about mitral valve prolapse, MVP? I have moderate MVP. Should my kids get tested?
Your kids should not get tested. While mitral valve prolapse is almost certainly rooted in your genes, it's not a single gene such that it very rarely travels through families. So if you've got mitral valve prolapse, even if you've had surgery, you don't need to get tested unless you said, I've got it, my brother's got it, my dad's got it, my uncle's got it. Then in your family, it would be stronger, but almost always you do not need family testing.
Got it. And this question relates to some of the case studies you talked about today. Corey asks, I'm 54. I have moderate to severe mitral regurgitation and in watchful waiting. Can I continue to lift weights, ski, and scuba before surgery? Will my exercise be limited after mitral valve repair?
You can continue to do whatever you like. Nothing will affect your valve. Some old-time doctors will say don't lift weights and don't exercise, but there's not a shred of data to support that. So yes, stay active, and provided your repair goes well, you should have no limitations after. But this term moderate to severe always bothers me because it sounds like saying somebody is short to tall. You're one or the other. So I would get some granularity on that. Do you have enough regurgitation that you should get it fixed now? And if the answer is yes, get it fixed. If the answer is it's more like moderate, get an echo every year.
Great. Well, Corey, I hope that helped you. And we are at the point of the webinar that we are going to, unfortunately, we still have another 50 questions to go. We're not going to have time to get to them, but please don't hang up on the Zoom call just yet. We're going to take a minute here Dr. Gillinov, on behalf of our community, I want to extend a tremendous thank you to all the help that you've given our community in the past, the present, and the future. Cannot thank you enough. I also want to thank all the wonderful people on the call today. We appreciate coming together with you as a community to learn about how to manage our valvular disease and get the best possible outcomes. And as we wrap up, what I would really ask you to do is to complete the survey so we learn more about your experience here on the HeartValveSurgery.com webinar. And that's going to be appearing on your screen as soon as I end the call. So Dr. Gillinov, thanks so much. And thanks to everybody on the call.
Thank you.